Welcome in, everyone. Happy Parkinson's Awareness Month. Thank you so much for joining us for our first webinar of the month. Today, we are having an Ask the Doc session with Dr. Robert Wiggins from Novant Health. And so today you have the opportunity to ask the questions you have about living with Parkinson's. We do have some pre-submitted questions that we'll go over, but you can also ask your questions live as well. And Dr. Wiggins is actually going to start us off by going over a brief introduction to Parkinson's, and then we'll get into the questions after. But without further ado, I'd like to turn it over.
Well, good afternoon. It's good to see all you guys. Thanks so much for joining. I'm a big fan of the Parkinson Association of the Carolinas, and really thankful and honored to be here to chat and try to answer any questions that you guys have. A good reminder would be this is for you guys and not for me, and not for Kiana either. So please feel free to answer any or ask any questions that you guys have. We will have some pre-submitted questions, but wanted to just to start off with a few different slides to kind of get the juices flowing, I guess. And some of you guys that have either been to presentations I've done before or seen some of my slides will recognize these slides, but wanted to just quickly go through these. So we'll start here. First, before we really move further, I wanted to just draw attention. I've been slowly starting to write little articles about Parkinson's disease and different treatment topics. The website is right here, parkinsons.substack.com, and there's a QR code. Feel free to take a look at that if you'd like to. You can view it without subscribing, or you can subscribe. Really doesn't matter to me. It's not in any way a money type thing. It's free. But mostly I just answer a lot of the same questions over and over. And I really like that because I can help out a lot of people. But this is one way just to try to learn a little bit more on your own as well. So feel free to take a look at that. I'll bring that back up later on. But just quickly, I do have just a few what we call disclosures, just a few different pharmaceutical companies that I work with that is important to let you know about, just to really be as transparent as possible. But quickly, so I work at Novant Health, which is in Charlotte. There are a few different locations. I am in the uptown or kind of central campus, what we call the Midtown Clinic. But I actually grew up just a little bit north of here in Mooresville, North Carolina. And so I know the area well, and I actually did some of my schooling here in the area. Went to Virginia and then went to New York City, and then I've been here in Charlotte for about 3 years. So we're going to hit these slides really quickly because I really want to leave all the time for you guys. But how do we know that someone has Parkinson's disease? And in a way, what is Parkinson's disease? What does Parkinson's disease look like? I don't like showing this picture because it's an outdated picture, but I think it's a good place to start with. And we'll correct this picture here in a second. But people who have Parkinson's disease have some of the 4 cardinal features. That's a tremor, slowness, some stiffness called rigidity, and then walking trouble called postural instability. And it's really important to remember that that picture is an old picture, right? With the right medicines and the right treatment team, there's a much different picture, a really different outlook that we talk about with patients. So it's important not to think about this person and this person alone, but that some people with Parkinson's still run and they still can walk pretty well. And they may have a tremor, but their life can still be very, very fulfilling. So we've talked about a little bit of the motor symptoms. Of course, there are non-motor symptoms. Those are more things like maybe depression, some anxiety, constipation, all kinds of different what we call non-motor symptoms. These are the symptoms that patients actually tend to be more bothered by oftentimes. So just know that we're able to talk about these symptoms as well today and answer any questions. Now, the reason that people have Parkinson's disease is because this pathway is affected. It's called the basal ganglia. And the reason is because this area here, right above the P, you can see on the right is the control, the left is the P. So this is a cross-section of someone's brainstem, and you can see that this area has less pigment or less substance there. That's called the substantia nigra, and in people who have Parkinson's disease, this is the area that's affected. Now, Parkinson's disease can affect different areas of the brain as well, and that contributes to why people have different symptoms, like starting with constipation or mood changes, motor symptoms, maybe some memory trouble too. All of these things are possible. Now, we'll talk about medicines, of course, a lot today, but I want to really emphasize that staying active and really focusing on nutrition can be really helpful. I like to say that medications are great and they really do a good job, but one of the ways that we really optimize someone's daily life is by making sure they're staying active, exercising, particularly that cardiovascular exercise, and then also making sure that they're eating well, right? We like to say you are what you eat. Think about it this way. If you're running a marathon this weekend, you'd probably start fueling for it today, starting to think about what do you need to make sure that you're eating and taking in to make sure you're ready. So I like thinking about that really for the whole journey of Parkinson's disease. We'll talk about some of the classic medications and some of the changes that happen throughout the course of Parkinson's disease, whether that's someone who has just recently been diagnosed or someone who has what we may call more advanced Parkinsonism. And we'll probably talk about today why that can be a misnomer and even be misunderstood among people who have Parkinson's disease. But lastly, outside of the medications, I just wanted to draw some hope in here. So every spring, early spring every year, there's this group that publishes this Parkinson's disease pipeline article, and this is the one from 2023. They've not come out with the 2024 one yet, but these are all of the medicines that are currently being studied for Parkinson's disease. So there's a lot of hope out there. There are a lot of new potential medications coming out. Quickly, the top medications here are called disease-modifying therapies. That's the DMT. The ST below is symptomatic therapies. All of these are potential medication options for the future. So effectively, we don't know if these work yet, and some of them we don't even know if they're safe yet. But this chart here, this picture, I think brings me a lot of hope because there is a lot of research going on. Just remember that just because you're not hearing about it doesn't mean there's not research going on. So I'm going to stop sharing my slides here and wanted to open it up to see if there were any questions, Kiana, that you wanted to jump to from our pre-submitted group.
Yeah, thank you. So let's see, our first question. Our first question is, when is the proper time to start medicine?
That's a great question. So whenever we talk about starting medications, there is always some people who feel like, oh, I want to wait as long as possible. One, because I don't want to be on medicine, possibly. And some people even have heard this, what really is a myth of, oh, let me wait as long as possible because I only have 10 good years of this medicine. We'll talk about this a little bit more later, but I mostly say the right time to start medications for Parkinson's disease or for the symptoms of Parkinson's disease is whenever the symptoms are bothersome enough that they're impacting your quality of life. So for example, sometimes I'll have a headache and sometimes the headache is not really bothering me, so I will not take Tylenol, for example. But sometimes it really does bother me and it's a migraine, so I have to take my migraine medicine. So effectively, because the medications that are currently available at this moment are more what we call symptomatic therapy, which means helping the symptoms of Parkinson's disease and not necessarily, as far as we know, affecting the long-term course of Parkinson's, then the real time to start is whenever you find that it's right for you, whenever your symptoms are bothersome. I like to say kind of two things quickly. I don't force anyone to start medicine, but I start to almost try to force them whenever someone is falling, if they are falling because they're not on medicine, or if someone is having such a hard time with their exercising, if they're not exercising because their symptoms are so bothersome. So those would be two reasons when I would say, no, you really got to start medicine at that point. Otherwise, it's mostly just up to someone trying to figure out, okay, do these symptoms bother me enough at this moment or not?
Thank you. All right, so our next question. So this person is experiencing frequent urination, elevated blood pressure, and ED. How do I know whether these are due to aging, Parkinson's, or meds?
Great question. Well, the most likely answer is it's probably all three, or at least probably related to all of them in part. So one of them was you might have to remind me. It's low blood pressure, I think you said, ED, which is erectile dysfunction, and then I think there's one other.
Urination.
Frequent urination.
Yeah. And then that's elevated blood pressure.
Oh, elevated blood pressure. Gotcha. Okay. Well, let's start like this. So one thing that's important to remember is those non-motor symptoms of Parkinson's disease. So the non-motor symptoms in this realm are what we call autonomic symptoms. The autonomic nervous system is the part of the body that kind of triggers that fight or flight response. And just like it does fight or flight, it also does what we call rest and digest. And so the blood pressure, the blood pressure and let's see, frequent urination and erectile dysfunction, all of those are related to the autonomic system. So blood pressure being raised up, that's going to be to that fight or flight. You're ready to go. The rest and digest, that's going to be more of kind of sexual function and urination, digestion, that kind of a thing. So the quick answer is it's related to everything. So if someone who has Parkinson's disease is probably having some worsening of these things from all of them. Effectively, the good answer is that whether it's coming from age or Parkinson's disease, we mostly treat it in the same way. Now, low blood pressure can come very frequently from a lot of the Parkinson's disease medicines. So, for example, carbidopa, levodopa, also known as L-dopa or Sinemet, or all kinds of different names we call it, that can actually lower your blood pressure. So the high blood pressure isn't necessarily coming from your Parkinson's medicines, but that could be coming from, aging. As we all get older, sometimes our blood pressure rises. It could somewhat be coming from the Parkinson's in that your blood pressure might just be fluctuating. But for the blood pressure, if the blood pressure is just really high, then I would say that's less likely to be related to the Parkinson's and your medicines, because traditionally Parkinson's and the medicines actually make your blood pressure a little bit lower. And so a high blood pressure would be something that would be best to talk with your primary care doctor about. And then low blood pressure would be more of a thing that you need to talk with your neurologist about. They may still use help from your primary care doctor, but that's when we start thinking about making sure someone's well hydrated, making sure that someone is being really strategic about the timing of their medicine, or there are actually medicines that are available in an extended release form or a slow release form. And sometimes those that they can be very effective, but they just don't hit you as hard. Because they don't hit you as hard, it might actually be better to not drop your blood pressure as quickly. And so those are some of the ways the autonomic system can impact someone who has Parkinson's disease.
Thank you. And looks like we actually have a question in the chat, so we'll go ahead and take that one.
Yeah.
Before we go back to the pre-submitted. So I had a hip and knee replacement surgery last year, and I'm still sore and stiff in my hips and knee. I have some gait issues as well, and wonder if these problems could all be related to Parkinson's.
Yeah, absolutely. So this is what I like to say. So I don't want to be a broken record, but again, it's probably related to a little bit of both, right? So what I like to say is that, we never like to exclude, there's almost no reason to exclude someone with Parkinson's disease from needed surgeries like hip surgeries, knee surgeries, that kind of a thing. What I like to say, though, is that it might take a little bit of a longer time to recover from these procedures. Now, that's not a year or two. I think the question was asked about, it's been going on for a year or more. What I would say is this, is that similarly to some of the autonomic questions, if you're still having some discomfort after a surgery and you have Parkinson's, probably one of the best ways to go about that would be, which I hope you're doing, is going to a physical therapist to work on these. So the same way that we would treat the Parkinson's, any discomfort or walking trouble from Parkinson's would be a physical therapist. And then the same way, if it was more orthopedic, would be a physical therapist. Now, a few other side comments is this, that if it's on the worst side of your Parkinson's, so let's say you had the surgery done on the right side and the right side of your body is the most affected by this discomfort, well, I would say that's probably more likely to be aggravated by the Parkinson's, right? That slowness or stiffness might be aggravating your symptoms. Then I think the last part of that question was, how do I know if these things could be affecting the gait? They definitely are affecting the gait. but trying to figure out whether it's more of a Parkinson's gait or more of a, hey, I just had surgery a year ago gait. The way that I would do that would be to try to have your Parkinson's doctor take a look at you, and if the gait pattern is a kind of a stereotypical gait pattern in Parkinson's disease, so typically more shuffling or what we call freezing, where someone gets stuck when they're walking, or festinating, which is these can be these almost freezing like almost really quick tap 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 kind of steps that people have. If that's what's going on, that's what's going on with your gait, then I would be more thoughtful about, okay, maybe we need to make a Parkinson's disease medication change. But again, really either way, if this was my patient, I'd say, all right, I would want to make sure that this person is having a really good rehab program. So I had knee surgery myself like 3 or 4 years ago, and I think I did pretty well with the rehab, but I don't think I did well enough. So what I mean by that is I still have some issues still going on in my knee. So I don't just give up, right? I don't just say, oh, it's too late. It's been 3 years. What I do for myself is I say, all right, well, I'm going to go back to physical therapy to work on that knee strength or that quadricep strength. And I'm going to do exercise. I'm going to stay active, that kind of thing. So I would say have hope, and hopefully these symptoms will get a little bit better.
Thank you. And we had one more question come in through the Q&A.
Yeah.
When should I be concerned about changes in on and off times from day to day? For example, the off times may be longer than the on times today. Yesterday, the on times were longer.
Yeah, that's a great question. Let me kind of take a step back and answer this. I'm going to try to, Kiana, pull up a whiteboard. Let me know if something goes poorly. Let's see. All right. Can you see the whiteboard now?
Yes, we can see it.
All
Sorry,
right.
I muted myself.
That's okay. No worries. So I'm going to draw these lines here, and we'll talk a little bit about on and off times. So just know that this is not to scale, right? So just doing the best job I can here with my computer mouse. So on and off time is really this. So whenever a patient is diagnosed with Parkinson's disease, they've never started on medicine, then really they spend a lot of time down here in what we call the off phase. That just means the medicine's not working. If the medicine is working, then we might call that on. And then if it's working, but it might be working a little bit too well, we'll say on with dyskinesias. So sometimes whenever we take the medicine, we feel really great and we get up into this on time. And particularly whenever we're first diagnosed with Parkinson's disease, we spend and we start the medicine, we spend all of our time in this on time. We feel pretty good. We feel pretty good, pretty doggone good. And we take the pill 3 times a day, and we're just staying right here steady in this on area. But as the Parkinson's disease, as the time we have Parkinson's disease lengthens, the longer we've had it, the more likely that medicine is to not do quite as good a job. Not because our body is becoming accustomed to it or used to it, but just because we might need a little bit more of that medicine. So off means whenever the level of the medicine in our body effectively drops below this area right here, and it's no longer working. So frequent symptoms of off is sometimes people feel more stiff, they'll feel more rigid, they might have more walking trouble. If their tremor goes away with the medicine, the carbidopa, levodopa, then, or also called Sinemet, then the tremor might come back whenever they're off. And that people can feel anxious, they can feel panicky, they can feel brain fog whenever their symptoms are off. And then they take their medicine, and typically 30, 45 minutes later, they feel on again. Sometimes this can just go back and forth all day long after they take the pill every time. So the question was, when do I need to be worried or concerned about on and off time? I would say that it's not necessarily a when do I need to be worried about it, like when do I need to like panic or worry about it, but it would mostly be, hey, like is that off time bothering you? Is it getting in the way of your daily activities? So I have one patient who really likes to go to her exercise program, and it's kind of smack dab in the middle of the day. So she has to perfectly time her medicine to be able to show up at the exercise program and feel really good and feel on. And so that's okay. She's doing okay with that. But the important thing is that there are ways to change the medicine dosing, right, to try to make someone feel better. So the way that one would do that would be trying to let's see here, trying to give to change the dosing. So rather than, the typical dose of this medicine is 1 tablet 3 times a day. If someone is having off time and it's bothersome and they never can go to their exercise class, or they always feel really bad, or they feel like they only have a few good hours, then what can be done is there can be kind of an extension of that. So rather than just being on this, just a very simple, what we call foundational dopaminergic therapy, which would be like your regular old Cinemet, we often can consider adding in this middle column here, this extender column. So there's a few different, these are branded versions here. There's a few different versions of other medicines that might actually last a little bit longer. So rather than giving you that peak right away and it going away after 3 or 4 hours, there are other versions of these dopaminergic therapies or medicines that might last a little bit longer. And so let me go to this just to explain. This is what I was drawing earlier on. So when we're first diagnosed with Parkinson's disease, and we take the pill 3 times a day, and we always stay right in the middle, this mild PD, we always stay right in the middle here, and we feel pretty good all day. The longer we've had Parkinson's disease, the more that blood level of the dopamine is going to get outside of this line, these lines here. And it can end up being too low and it's feeling off, or it can actually get quote unquote too high a little bit where the medicine works too well and people have dyskinesias. So more or less, I think a good summary of my answer would be, hey, if it's, I wouldn't worry about it, but if it's bothering you, I would bring it up to your doctor and have them consider whether changing your medicine, either increasing the frequency of your dosage or switching to or adding one of these extender medicines might be the right answer. I think I covered that question. If whoever asked that, if I didn't cover it, please send another question back in, and we'll try to answer it better.
Thank you. All right, so we have one other question, and there's actually two questions that are fairly similar, so I'm going to clump those in together.
Okay.
So the first part is what can be done about sleep issues and PD, and then the second part is, do you have any suggestions for ways to get better sleep?
Yeah, great question. Let's start with the obvious, exercise. I sleep really well myself, not to brag, but what I know is that on days that I'm not exercising, I don't sleep well at all. And so really exercise is a really, really good way to tire yourself out and make you sleep well. So exercise is really important. Of course, really focusing on avoiding caffeine before bed. That's the normal type things. We call this sleep hygiene. From a Parkinson's disease specific perspective, I would think about this. If you're not getting good sleep, be more specific. So why are you not getting enough sleep? Are you having trouble falling asleep? Are you waking up in the middle of the night and then falling back asleep back and forth? Or are you waking up first thing in the morning and you just are like 3 or 4 or 5 a.m. and you just can't fall asleep again and you're just kind of awake? So why are those important? Why is it important to differentiate? Because we treat those in completely different ways, right? So the first thought I would say this, if you're really, whichever one those are, if you're waking up and you're feeling stiff, rigid, if you're feeling just really uncomfortable in bed, if you can't turn over, if you are having trouble, shuffling over, getting in and out of the sheets, getting out of bed, well, one of the a really likely possible explanation is that your medicine is worn off, because oftentimes the last dose we take might be around dinner time. So we can actually give bedtime doses of this medicine that people take maybe 30, 45 minutes or right before bedtime or right at bedtime. And that lasts through the night to try to make people feel better. So the first answer to that is, if you're having sleep trouble, and you have Parkinson's disease, make sure you're exercising. But then the second Parkinson's specific answer would be, think about whether your medicines are working or not. Do you feel stiff? Do you feel rigid? That kind of a thing. If you're waking up in the middle of the night frequently to use the restroom, we would treat that in a different way, right? I like to tell a story where I had a patient and their family come in and they were adamant that they really wanted to sleep throughout the whole night, but they're waking up 5 or 6 times a night to urinate, to go to the bathroom. And the reality is that if we're going to put them to sleep through the night and they were previously urinating 5 times, well, they might be able to sleep through the night, but they might wake up and the bed might be wet, right? And so if the problem is frequent awakenings because of urination, then we should treat that increased frequency of urination overnight. And one way that I do that is we try to avoid water before or fluids before bedtime, but I try to work closely with our urology colleagues. They're just more familiar, particularly with men, how to treat these issues, making sure that it's not purely a prostate-related issue or other, even with women, urethral irritation-related issues. Those can cause that frequent urination. Those would be kind of my temporary thoughts. I am always very careful about giving sedative medications. We do oftentimes prescribe either or recommend melatonin or a medication called clonazepam for this thing called REM sleep behavior disorder. Now, it's a little controversial because the few studies that have been done about those medicines, they kind of have some questionable results, but a lot of patients feel like these medicines are actually pretty helpful, so we will use those. Those might help people sleep through the night. Unless we really need to turn to things like trazodone or mirtazapine, these are really kind of sedating medications. I try to avoid those. So effectively, it would be great if, before you go to your doctor to talk about your sleep troubles, you've already kind of done the regular things. Okay, I'm exercising well. Okay, I'm not drinking fluids right beforehand, not using screens, etc. Because then that will let us have time to really figure out, okay, do we need to make a medication change? So yeah, I think that's a good place to start with sleep and Parkinson's disease. And if there are other questions about sleep, feel free to throw those at us. We'll try to tackle them.
Thank you. And that's actually all the sleep questions that we have submitted right now.
Okay.
Thank you. Let's take one more question here that we have pre-submitted. So I find the fine motor skills like tying shoelaces seem to take forever. Can I speed it up? I've reverted to slip-on shoes.
Yeah, I guess I kind of have two thoughts about that. I think, my first thought would be there's nothing wrong with slip-on shoes. If that's okay with you and you want to wear slip-on shoes, then I think that's fine. I don't think that we should try to be as normal as possible just for purely being normal. No one's really normal, right? Everyone has their afflictions, everyone has their quote unquote issues. But if you notice that your speed of doing things is slower, then I would ask, is that constant throughout the day? Is it that you're always having trouble tying your shoes, or is that mostly first thing in the morning, or is it always, 30 minutes before you take your next dose? If it's always only in the morning or right before you take your next dose, then remember that slide we were showing, maybe you're just dipping down and the medicine's not working quite as well anymore. If that's the case, then the answer is to try to improve or optimize your medications. If it's more about no, it just happens all day long, then the two thoughts I would have would be practice, or the second thought would be, there are people that are trained actually to help with some of these issues. The person that would help with this would be an occupational therapist. They might either be able to give you some tips and tricks about how to do that task faster. They might say something like, oh, okay, well, why don't you, there might be this device that you could use. Or they say, oh, well, instead of using lace-up splooge, maybe Velcro might be, easier. Or maybe they have shoelaces now that are just stretchy. So a lot of times runners will, instead of having regular tied up shoelaces, they'll have these stretchy laces so that you can get out of them pretty quickly. But you don't necessarily have to go, when you're putting your feet back in, you don't have to lace them back up. So So that might be an option. I think the summary of that thought would be, you know, we kind of kind of that idea of don't sacrifice good enough for perfect, or there's some analogy like that. Mostly, if we're having a lot of trouble with our shoes, for example, maybe we just use slip-ons, or maybe we use these elastic laces rather than just always struggling with the shoelaces. But I don't think that this shoelace issue is probably going to get a whole lot better, which is kind of why I'm suggesting we look for some kind of workarounds outside of that.
Thank you.
Sure.
Let's see, we have another submitted question here. So this person wants to know more information about dementia and cognitive changes in Parkinson's.
Yeah, absolutely. So I'm actually going to show this slide again here. So, when we think about Parkinson's disease, we oftentimes think about just the tremor, right, or the walking trouble. But the same changes that kind of cause the constipation and some of the decreased ability to smell and the tremor and that kind of a thing, those changes do move through the brain. And when they involve what's called the cortex of the brain, that's kind of that outer lining of the brain where all the kind of ridges and bumps are. That's when people can start having some cognitive concerns, or easier said, memory trouble. The first thing that I would say about that is to just reassure you that everyone has memory trouble. I have memory trouble. So we all have memory trouble. And so just because someone's having memory trouble, I wouldn't want you to jump straight to, oh, first off, this is not necessarily part of the Parkinson's disease, right? It could be. We'll talk about that in a second, but it's not necessarily immediately related to the Parkinson's disease. There are a lot of my patients who have Parkinson's disease, and also those who don't have Parkinson's disease, who express that as they get older, they are noticing more and more memory trouble, or more and more cognitive trouble. In Parkinson's disease, that is more common than your, say, average Joe walking down the street who's of a similar age. That typically happens in, first with kind of, initially recognized as memory concerns. That can turn a little bit to someone not feeling quite as confident, or not like they're able to be as independent. And that's when we start to say, start looking to make sure that someone that cares about them, a friend or a family member, is showing up to their appointments, just to make sure that everything is going okay at home. Effectively, we all forget things. And so whenever we're starting to notice even a little bit of memory trouble, we should start implementing strategies to try to keep us doing as well as possible. So that would be making sure that we take our medicines on time, making sure that we're not taking too many sedating medications. The majority of people that I see for new memory referrals, we say them, are people who are worried they have dementia. The reason is because they're on strong medicines that slow down their memory, or depression and anxiety. I personally think that the biggest reason that people in America have memory trouble, of all ages, is depression and anxiety. So I think giving yourself an honest look and saying, okay, do I have those? Are those getting in the way? That's an important thing to do. Now, if someone does have cognitive trouble or memory trouble, specifically related to their Parkinson's disease, there is actually some good news in that there are medicines that we can use that are more likely to help someone's memory trouble if they have Parkinson's disease than if they have Alzheimer's dementia. So though we use the same medicines from Alzheimer's, they're actually typically thought to be a little bit more effective in Parkinson's disease. And so we try not to be too slow in pulling the trigger on using those medicines if someone is having those issues. Now, the next kind of thought that I will bring up is, excuse me, something that we try to be open and honest about, called hallucinations. So sometimes people who have Parkinson's disease will have hallucinations, and hallucinations, it's important to emphasize that these happen when you're awake. So it's not just vivid dreams, but it's when you're awake. And what they are is just typically seeing something that's not there. the vast majority of my patients that have these, they're not really worried about them. It's just kind of there. They recognize that it's not real, and we just kind of ignore them. But as someone has Parkinson's disease for a longer amount of time, we do see these hallucinations start to crop up, and they can become bothersome enough that we want to treat them with stronger medicines to try to get them to stop. So I think this is another similar thing of, oh, if you are starting to have some trouble with your memory, or even if you're having hallucinations, let your loved ones know, but also let your neurologist know. One last thought is we like to make sure that there are no medical issues contributing to memory trouble as well. So we've had patients who have low B12 levels or uh, like not balanced thyroid levels that have a lot of memory trouble. And then we get those corrected and they feel a lot better. So oftentimes it's not a one-time thing of, oh, let's just fix the memory. It's okay, let's take the next few visits, the next few months to really try to work on this to make you feel better.
Thank you. Looks like we have a question that was submitted here in the Q&A. So this person recently had DBS surgery, and they're going through adjustments right now, and they are starting a daily log of how they feel and sending emails to their coordinator. The question is, when should I have started, and how detailed should I be?
That's a good question. So thinking about kind of a daily log. So there's a little difficult to answer right off the bat because I don't know you, or at least I don't think I know you personally. So I'm not necessarily the best with names, better with faces. But if you were my patient, I would say that I think that um, for the first, say, few weeks or a month or so, it is important to be pretty detailed about what you're feeling. I don't think that means take detailed notes every day, but or sorry, every hour. But I would say that maybe every day you give yourself a few notes, like a sentence or two. Today I felt pretty good because my tremor was better, or today I felt bad because I felt off balance when I was walking. Those would be important changes to keep track of. Um, I think the other comment here would be as detailed as you want your neurologist to be. Meaning, if you have a symptom that's bothersome, you should write it down. Um, you know, a lot of times when patients come into my clinic visits, whether they have DBS or not, really my biggest question is like, what's wrong? Like, what can I help with? We of course have our normal questions that we go through, but the real question is, what's really bothersome to you? What can we affect? What can we try to make better? How can we improve your quality of life? So that's what I would do if I was a DBS patient. I would have a list of the things that are really bothering to me. Now, if I could make one other comment, I would say that every time you make an adjustment on your deep brain stimulator, I think at that point it would make sense okay, let's start taking notes again. And effectively, whenever you're thinking about deep brain stimulator, answer the questions, which Parkinson's symptoms is it improving? And then think about, is it giving me other side effects? And so sometimes something can help your tremor, but it might cause you to feel a little bit of tingling in that hand. And so we got to figure out, can we adjust the settings so that you have tremor control, but not have the tingling? If I could also point anyone who is kind of thinking about deep brain stimulation, there's a really great resource from the Davis Phinney Foundation. It's called their DBS or Deep Brain Stimulator worksheet. I've started handing it out to some of my patients. It just really goes through a really good way of saying, what do you expect out of this surgery and what are you hoping for? Just because I think in Parkinson's disease, we oftentimes say, oh, deep brain stimulation is like the holy grail. I love deep brain stimulation. I think it can be incredibly effective for the right people. But part of the reason it's so effective is because we're picking the right people and we're making sure that our expectations are on the same page. So take a look at the Davis Phinney Foundation if you're interested in deep brain stimulation. They have some great resources.
Thank you. Let's see here. We are running low on questions pre-submitted. So the next one, someone said that they need more info on the home care. Their wife currently takes care of them, and they want help for her. And not many people want to talk about that. Dr. Wiggins, before you start on that, I just want to let you know that PAC is happy to connect you all with the resources in your local vicinity, if you're based in Charlotte or not. That is something that we can assist you with in helping you to locate the best services for you. So that's something I will find your contact information from registration and reach out to you about connecting with the resources. But Dr. Wiggins, if there's anything specifically that you'd like to add there, feel free.
Yeah, I would emphasize that if you kind of have to remember that you know even in Charlotte, these like larger healthcare businesses, right, don't necessarily um, they may not have planned to provide some of these resources, which I think can be unfortunate. So I would very strongly agree that, if a patient of mine is needing these kind of things, I would have them call PAC, the Parkinson Association of the Carolinas, mostly because they're on the grounds, right? They know kind of what's going on. They know the most active groups, the best home health issues, that kind of thing. Effectively, I would look at that question this way. The answer, there's three kind of sources of help. One is paid help, where you're going to have to pay out of pocket. That means your insurance does not cover it. Another would be probably more likely temporary help that your insurance might cover. We'll talk about that more in a second. And then the third would be kind of completely unpaid help, which would be like friends and family. And so the first thing I would say is that I think it's a really great thing that you noted. If I understand the question correctly, you had kind of noted that that your wife is taking care of you, and you're wanting to get help for her. And so it's important that we're thankful for the people that we know and love with Parkinson's, and it's also that important that we're thankful for the people that take care of those people that we know and love with Parkinson's, right? So caregiver support, caregiver burden, that's really, really important. What I would do is this: I would reach out to PAC. I would reach out to your local county. Mecklenburg County has some decent resources to try to help out, whether that's transportation, Meals on Wheels, other type things. If we're talking more about caregiver support, caregiver burden, I would join a support group, or at least allow your caregiver to join the support group. Like, let them do that even if you're not able to or don't want to, just to give them some extra support. There are other groups that, just to be honest, the name is not coming to the top of my head, but I have like 10 flyers in our waiting room that have their information. Reach out to PAC, they might have those information. But there's other groups, like paid groups, like you could, kind of the typical like Visiting Angels, Home Instead. There are, gosh, I just can't remember the name of the one that I really want to bring up right now, but there are other groups. Those are going to be more like paid help, where you kind of pay out of pocket. And then just lastly, I would say that it's just underscore the fact that it's important that that caregivers have help, and that we're kind of spreading the responsibility and spreading the load, because particularly people that are kind of like committed for life, whether that's marriage or brother sister or brother whatever, we want those people to be there for the long term. And so I think it's important to make sure that both our people with Parkinson's as well as the caregivers feel well supported.
Thank you. And I know we are almost at 3 here, so I want to let you all know that, of course, if you all have any questions, you are able to ask them live or use the Q&A box. If you'd like to ask your question live, feel free to raise your hand. I think we have time for maybe about 3 or 4 more questions before we wrap up today's session. But I welcome you all to ask the rest of your questions if you have any. Otherwise, we will dive into our just some general questions.
Yeah, if anyone has questions, feel free to raise your hand and ask. Kiana, you let me know if anyone raises their hand. Otherwise, I'm just going to talk, because I feel like there is so much stuff to talk about in Parkinson's disease. And I'm going to kind of jump back to that 2023 pipeline that I talked about. because a lot of people always ask about, are asking about what is out there. And there are, remember, I had emphasized that I'm going to count them. I'm going to look to the side. There are 1, 2, 3, 4, 5. This was last year, right? They don't have that updated for 2024, but there are 6 different therapies that are in what we call phase 3. So that's the final phase that is trying to prepare and make sure that medications are safe and effective in the disease modifying realm. That's great. I'm pretty sure that in 2022 there was 3, right? And so that's more, right? There's really a lot of exciting things going on. A lot of people always say, well, what drugs are the closest coming up? Well, there are, even in this year, I can think of, off the top of my head, 2 different therapies and at least 1 or 2 other pills that are going to, probably in a way revolutionize the way that we are treating what we'll kind of say, I'm just going to loosely, lazily use the word moderate Parkinson's disease. So remember all those fluctuations I was talking about? There's some really, really exciting new therapies coming soon that have not been approved by the FDA at this moment, but for the most part, people think they are going to be approved. The kind of same or similar versions have been available in Europe, and I believe one was recently or will be launched recently in Canada, that are effectively what we call continuous subcutaneous dopaminergic therapy. So rather than having to pop a pill 6 times a day, this will be more like an insulin pump where therapy can be delivered like to the skin, right, all day long. And the beauty of that is that rather than having to take the pill, the dose jumping up and then falling back down, up and down all day long, it can be much smoother. That's good because that's the way that the normal brain is, right? So we talk oftentimes about making sure someone's on, but we also want to try to recreate from a biochemistry perspective the normal environment in the brain as much as possible. So neither of those are approved yet, but I'm very excited about those potentially being approved soon. That doesn't mean everyone's going to go on them. If you're doing pretty doggone well with 1 tablet 3 times a day, I would not recommend you change. But if someone is having a lot of motor fluctuations on, off, and like they're on a roller coaster all day, that might be a really good, new kind of therapy to consider. Other therapies for the people that are having a lot of on and off is either a longer acting version of a pill or something that's currently available called Duopa. Duopa is an levodopa intestinal gel, so it goes directly into the digestive system. It's given via medication port, via kind of a box or a small box that would hold all of the medication. That can just provide more continuous therapy. And just lastly, deep brain stimulation is another therapy that can provide more around the clock continuous dopaminergic therapy. So those are exciting. And then another thought is that from these new medicines, there's one that we've been kind of looking out for a while. The name of it is called exenatide. It's currently a diabetes medication. They do kind of keep pushing back the release date every few months of this. Not release date for the medicine, but for the trial. So we're still waiting for that phase 3 trial. The phase 2 trial was reassuring, and that's why they did the phase 2 trial. It's already used currently in diabetes patients, and hopefully it'll be shown safe and shown effective for slowing down the progression of Parkinson's disease. That's really, really important. At this point, outside of making sure that we're optimizing eating well, the most important way to slow down the progression of Parkinson's disease is exercise. Any other questions right now, Kiana?
I have not seen any other questions come through.
Okay.
Again, you all, if you have any questions, again, feel free to raise your hand and you can ask your question live. If you want to maybe answer one of the general questions that we talked about.
Sure, yeah, absolutely.
Sure. Let's see here. So this one, I have other health conditions. How can I best manage these conditions together?
Yeah. So as we all get older, including myself, we start to develop some diagnoses, right? And I think that like someone had mentioned earlier on, it can be hard to figure out, is this symptom coming from the Parkinson's disease, or is it coming from the from this other condition, or maybe it's just some maybe getting a little bit older. I think that getting educated or learning as much as you can about all the conditions is actually very important. Whenever someone is initially diagnosed with Parkinson's disease, I actually specifically tell them not to learn anything about Parkinson's disease for the next 6 weeks. Mostly, I just worry that they're going to kind of get in over their head. But after someone has had the condition and they're starting to kind of wrap their brains and emotions around it, I think it is important to start educating yourself. Mostly trying to figure out, whether, for example, if someone were to start to have, um, let me think of, if their, big toe were to start turning purple, and they were to start having, their feet, their one leg would be really cold, and that kind of thing. That's not probably Parkinson's disease. That might be more like a blood clotting disorder. So it's just important to know whether something is likely to be related to Parkinson's disease or not. So attending groups like this or other learning sessions is important. The other thing that I would say is, medications can really often interact. So a lot of Parkinson's groups really focus on what medications should you not take if you have Parkinson's disease. The most simple way to underscore that is got to be careful with mental health medicines, particularly antipsychotic medications. This can really hurt people who have Parkinson's disease. And we have to be careful about nausea medications. Those are the real big ones. So those are big no-nos. And then just lastly, I was going to say, my belief is that if you find a doctor that you like for each different condition, they are much more likely to be a good team together. And so I don't think that it necessarily means you have to get all of your doctors at Novant or all your doctors at Atrium or whatever. That's not quite as important to me. What's important to me is that the people that are on your team are really invested. So I won't say this person's name, but there's one therapist in the area, and this person I think does just great care, but she doesn't work right in the Charlotte, like the proper Charlotte area. So patients have to travel. Well, if a patient is having a lot of swallowing trouble or speech trouble, I know that this person is going to really do a good job. So I really, really say try to find a good team, right? So not necessarily the person that is associated or is closest, or who has the most diplomas on their wall, but someone who's going to be really invested in you is the most important thing.
Thank you, Dr. Wiggins. And that's actually a good plug-in for our next webinar next week. And so that is on building a proper care team with Catherine Cherry, who is a social worker. And so be sure to tune in for that as well. You can learn a little bit more there. Okay, well, I think that's all. I don't see any other questions that have come through. But I want to thank you all for joining in today and asking your questions. I hope that you were able to get all of your questions answered and learn a little bit more about Parkinson's and living well. Thank you, Dr. Wiggins, for being here and taking the time out of your day. And again, happy Parkinson's Awareness Month to everyone. And be sure to tune in for what Pat has coming up next.
Thanks, everyone, for joining. Have a great day.
Bye, everyone.